Hi, everyone. Welcome to the Oregon Rural Health Conference presented by the Oregon Office of Rural Health. I'm Rebecca Dopert, Field Services Program Manager and moderator of today's session. We're going to start with some brief housekeeping. First, I'd like to thank the partners whose support has made it possible for the Office of Rural Health to present the conference at no cost to participants. Many thanks to our gold partners, All Care Health and the Oregon Rural Health Association, our silver partners, Eastern Oregon Coordinated Care Organization and the Oregon Association of Hospitals and Health Systems, and the River House on the Deschutes, our bronze partner, RQI partners, and our copper partners, Westcom, the American College of Education, and Inquisic. Participants should have received an email with a link to our conference app. Use the app to visit our partners' virtual booths, enter to win prizes, network, and share photos of your hometown or region. And please don't forget to do the survey about the session. Survey completion is required for those seeking CE credit, and any completion gives you a chance to win a $100 gift card. And with that, let's begin the presentation. Your presenters for this session, I'm happy to announce, are Sabrina Ballew, Supervisor of the Mobile Integrated Healthcare Program for Mercy Flights, Keshia Bigler, Population Health Manager at Columbia Pacific CCO, and Jessica Marcum, Community Paramedic at Umatilla County Fire District Number 1. And with that, I'm going to hand it over to Keshia.
Thank you, Rebecca. Hi, everyone. My name's Keshia Bigler, and I'm going to be kicking us off today for the topic, Making the Case for Community Paramedicine in Rural Communities, Evidence and Lessons Learned from Rural Models Around Oregon. Next slide. Just to recap so you can kind of see what our faces look like in this virtual environment. Today you'll be hearing from myself and Sabrina Ballew, my co-chair for the Oregon Community Paramedicine Mobile Integrated Health Coalition, and Jessica Marcum, who serves as our secretary extraordinaire. Next slide. And just to recap, today we're going to be talking to you all about different models of community paramedicine across Oregon and mobile integrated health models and how they can benefit rural communities. And we hope to provide an overview of how you might think about developing a proposal to start a program in your local community. Next slide. All right. So first, on behalf of the Oregon Mobile Integrated Health Coalition, I'd like to just share our mission and vision as a coalition. Our mission is to build, advocate, and enhance mobile integrated health and community paramedicine programs in Oregon. Our vision is we strive through public and private partnerships to change the culture of how healthcare is delivered through sustainable, innovative systems change that results in cost savings, improved patient experience, and enhanced community health for all people in Oregon. And next slide. All right. So I'm going to start with an overview of MIH and community paramedicine in Oregon. We recently completed a statewide survey with our various coalition partners to get a sense of what the current environment looks like around MIH and community paramedicine. So I'm going to highlight some of our findings for you, and then I will turn it over to my colleagues to provide some more details about their specific programs. So next slide. So currently throughout Oregon, we have several programs operating in various counties. Some counties have more than one program that touches folks who live within their county borders. You can kind of see the counties that are darker have more than one program operating in them. And then most of that is really kind of up and down that I-5 corridor. And we do have a program out in Eastern Oregon as well, and then a couple in our coastal region as well. Next slide. Thank you. And we asked folks what specific populations were they predominantly focused on in their programs. As you can see, majority of people who responded indicated that they really aim to support all community members, regardless of the type of payer that they have. In terms of program focus areas, we wanted to learn more about what types of programs and interventions people were offering through their program. As you can see, there's kind of a wide variety. Most frequently, people are focused on supporting community members who are frequent 911 callers, who are frequent emergency department utilizers, helping people get re-engaged with primary care, supporting people during transitions of care, chronic condition management, and working also with targeted populations such as our houseless populations. Next slide. One thing we wanted to really highlight are some very key partnerships that are essential to our existing programs. Partnerships are kind of really pivotal for a program to be successful. And so many of the programs across the state reported having close partnerships with primary care providers and clinics, the behavioral health clinics or community mental health programs, hospitals, county public health agencies, and then various organizations to meet social needs like housing authority or agencies, food banks and pantries, other types of social safety net support such as like WorkSource, DHS, and then things like substance use disorder treatment agencies, payers, or coordinated care organizations. And next slide. One thing we wanted to highlight was how are these programs funded, because it is a question we get asked quite often. Currently, there isn't really a kind of concrete answer to this question, but most programs are currently being funded through grants, or the position FTE is built into the departmental or agency budget. They've established a contract or signed a letter of agreement with a partner organization. They're braiding funding from various sources, funds from the city general fund, or through partnerships with healthcare providers. As an example, one of our programs has a close partnership with the OHSU School of Nursing, where student nurses do some of their precepting in partnership with the fire agency. Next slide. And really to reiterate how partnerships are really essential, it's also a main source of receiving referrals into the programs for many of our coalition participants. So folks are receiving referrals in a variety of ways. Some examples are 911 crew-based referrals, so those would be really focused on those frequent 911 callers. Other emergency responders, such as the police department or other EMS or fire and rescue departments. Coordinated care organizations. So coordinated care organizations commonly have their own case management or care coordination team within them, and so partnering closely with those teams to coordinate and get referrals for members. Primary care clinics and providers, hospitals, so things like follow-up post-emergency department visit or for folks who are being discharged from an inpatient stay. Behavioral health providers, particularly folks with serious and persistent mental illness who are engaged with behavioral health but also have co-occurring physical health needs. These worker types can be really essential in helping get those needs met for that specific population. Other examples include partnering closely with home health agencies, crisis services, and then palliative care or other groups such as DHS or APS, APD. And one of the beautiful things about this model is that our community paramedic and mobile integrated health providers are able to meet clients where they're at, literally speaking. So when we ask people where they most commonly interact and work with clients, most frequently, they report working with people in their home or their place of residence, so wherever they're living, which could be a homeless camp, a transitional housing, their actual home, wherever they reside. They also meet people in the community, so in parks and libraries and other settings, and occasionally will attend provider appointments alongside their clients. And most frequently, they're working and communicating with their clients face-to-face or over a phone call, and occasionally do some text messaging back and forth with individuals. The next slide. And then to give you a sense of some common intervention types, some of the work that our providers do include taking vital signs, medication reconciliation and education, conducting home and environmental safety inspections, doing lab draws, point of care testing, collecting infant weights. One of the big areas that they work in is resource connection related to social needs, so food insecurity, financial supports, housing instability or needs. Providing health education, monitoring chronic conditions, doing some client advocacy work, supporting clients getting reconnected or engaged with primary care, specialty mental health, substance use disorder treatment or providers, connected to care coordination resources. They do houseless outreach. They'll review discharge plans or summaries and care plans with the client. And then they also partner closely with existing provider teams and local multidisciplinary teams, attend care coordination meetings, huddles, and different things like that. So next slide, thank you. And then, of course, we want to be able to measure and evaluate the impact of the program. So these are some of the data indicators that various programs are collecting to be able to measure impact of their program. I won't run through all of these, but some key ones are reducing 911 calls, reduction in transporting people to the hospital via a 911 call, improvements in social determinants of health using various surveys and survey tools or screeners, improved medication adherence, improved engagement with primary care, and reduction of potentially avoidable ED, emergency department utilization. And next slide. I wanted to just kind of wrap things up to highlight this work across the state. The folks who are leading these programs and providing this work, boots on the ground, working with our various communities across Oregon, have been doing this since about 2015, 2016. The model just continues to grow, and there continues to be increased interest in this. And I just wanted to highlight that the work people are doing in the state has actually been recognized on a local and national level. You'll see some really awesome programs highlighted here, and I included all the links so you can go ahead and explore at your leisure. But I just wanted to point out that we're doing some amazing work, and it's becoming more and more recognized. And so I am now going to pass it to my colleague and co-chair, Sabrina Ballew.
Southern Oregon, serving the Jackson County. And today we're just going to cover a little bit of our history, when we got started, how we got started, and our partnerships.
Sorry, I'm going to cut you off. You were unmuted for a second. Can you start?
Oh, fine. Okay. I'll start again. Sorry.
You're good.
All right. Start over. All right. Thanks, Keshia and Rebecca. My name is Sabrina Ballew, and I am the supervisor from Mercy Flight's Mobile Integrated Health Care down in Southern Oregon. We serve all of Jackson County. And I'm here today to talk a little bit about how our MIH program got started, some of our partnerships, how has it evolved over the last few years, and where we are now, and then some of the work that we're doing. So maybe give you some ideas if you wanted to start your own program in your area. So next slide. Next slide. So a little bit about Mercy Flights. We are a nonprofit air and ambulance service. We were founded in 1949 by George Milligan, and we serve all of Jackson County and outlying areas for emergent air transports and ground. We developed our MIH program in the beginning of 2016 after doing a bunch of research in 2015, and we serve all of Jackson County with this program. So a little bit about me. I've been a paramedic since 2012 with a high interest in MIH work, and I have 10 years in EMS. I've been a student and a volunteer firefighter for 5 years, and then I'm co-chair of the Mobile Integrated Healthcare Coalition with Keshia. Next slide, please. So Mercy Flight's Mobile Integrated Healthcare Program was launched in 2016 in partnership with Providence Medford Medical Center and a local CCO, Jackson Care Connect. We started our program off focusing on a primary focus on high utilizers of EMS and the ED. We called that program the HUG program. That program was quite successful, and we'll show a little bit of the results of that at the end of this. But as that grew, we started dialing in our programs a little bit more. So in 2017, we continued the focus on the HUG program, and then we began to develop our transition of care program. And we're just going to call that the TOC program. And the focus with that is to reduce readmissions from hospital discharge. And then we also had a little bit of additional grant funding from Providence Medical Group to serve our community outreach patients. And those are the patients that are underserved or do not have insurance and really just need to be connected and make sure they're well wrapped. 2018 brought a few more changes, and we shifted our focus primarily to the transition of care program. And then we also continued our community outreach program. Next slide. So in 2019, in the middle of 2000, I'm going to start that one over again, sorry. In 2019, we added in a rising risk program. This program was really unique. This program focused on patients that were using the ED as primary care, and they may not have had multiple ED visits. They just were using the ED as primary care instead of going to their providers. So we continued to do the work with the transition of care. That program was very well developed, and we worked very closely with all our community partners to make sure that was developed. And then with the rising risk program, we increased that work by meeting patients in the ER, connecting them, finding out what their gaps are in care, and then connecting them. And then 2020 brought quite a few changes for pretty much everybody. We continued our work with the transition of care and the rising risk program. And then we have a partnership with OHSU to do a little bit of research to find out where gaps are in our area. And then we partnered with Jackson County Public Health to do the Safe Sleep Coalition and the dose education on scene for patients and families in need to have a safe sleep environment for their infants. And then COVID happened. So COVID changed our focus in that. So we continued all of that work that we were doing, our rising risk, and our TOC program, and then the partnership and the safe sleep. But the way we did this work had to change. So we partnered with Jackson County Public Health to do some outreach mobile testing for COVID. Then our team also implemented telehealth until it was safe to meet people in public and face-to-face. And so that actually kind of upped our engagement with patients so they could see who we are. And so we learned telehealth and how to make that happen. So again, we would talk to them via phone, Skype, life size, or text. And then just recently, we had another change, and our county was affected by the Alameda and the Open Chain fires. And that is beginning to shift our focus a little bit in the fact that we are trying to figure out outreach for those that have been displaced and lost their homes. So that is a program that we are developing currently. Next slide. So a little bit about our team. We have a very multidisciplinary team. We have our leadership team that's above us and supports us. On our team, we have a full-time paramedic with 26 years of experience in the ground and EMS. And then we have a full-time EMT. And then we also have 2 casual providers, and those are providers that help fill in when we have vacation, and one of each discipline, 1 EMT and 1 paramedic. Our team is also cross-trained as CHWs, and we do attend the local college to get that certificate. So along with being trained CHWs, our providers receive additional training in medical assisted treatment for substance use, mental health, chronic disease management, and motivational interviewing. Next slide, please. So as Keshia covered, some of our interventions are we do a full social determinants of health for every patient enrolled. That is an interview tool that we use for every single patient that we meet. And the reason why this is important is they may tell us, no, we have no gaps in care, but when we start digging, we find out they have food insecurities, they have housing insecurities, safety insecurities, or they may not just like their provider. They'll tell us that they're assigned to a physician, but the physician doesn't listen to them. And then we also have disease-specific protocols that our team follows, so ensuring that every single patient, whether it's diabetic, CHF, COPD, they all receive the same interventions. The patients enrolled in our program receive a full medication review that is comparing what their doctors have prescribed them, what the hospital has prescribed them, and then what they actually have and or we're able to fill at the pharmacy. We provide patient education on their diseases and why medication adherence is important. For the patients that are unable to pick up their medications, which this seems to be a pretty big gap, our team will actually go out and pick up the medication from the pharmacy and deliver it to the patient, ensuring that they have what they need to be successful. Our team also performs a full fall risk assessment and home safety assessment, and those are for the ones that will allow us to visit them in their home. That ensures that there's no trip hazards, they have a smoke detector, and we will connect them to whatever resource they need to have whatever gaps met. And then we will also connect them to the right provider who will meet their needs. And then, of course, care coordination. Next slide, please. So a little bit about our results for a transition of care program. These results are from 2019 and for the patients that were actually actively enrolled in our program. This data is also taken from patients that we were able to track 90 days before of the utilization and 90 days after. So this may not be a full capture of all our patients, but this is so we ensure that they have all the data. So with our patients, as you can see, prior to our engagement, they had 490 ER visits. During enrollment, they dropped that to 249, and then 90 days post-enrollment, they had a reduction of 156 for those patients. So that is a reduction of nearly 93.44% for those patients. And then also for inpatient, we had a reduction of 86.78 for inpatient stay. So with those patients, they had 124 inpatient visits prior to our engagement. During our intervention, which is anywhere from 30 to 45 days, they had 41. And then 90 days post-discharge and post-discharge from our program, those same exact patients had only 18 readmits. We also tracked the observation in there also, so you can see the results on that, just depending on the classification the hospital put them in. Next slide, please. So on this slide, we're talking about a little bit of the health score improvements that we had for our patients, and we focused on how they felt about their anxiety, mobility, pain and discomfort, self-care, usual activities, and an overall health score. And we interview these patients and ask these questions when they enroll in the program and then when they graduate the program. And so as you can see, we had about a 35% increase in overall change and improvement. And then for their overall health score, we take it from a 1 to a 10, and 1 being the worst they could be and 10 being absolutely wonderful. So pre-enrollment, they were 4.92, and when they graduated from the program, they were 7.36. And with that, I am going to turn it over to Keshia. Oh, gosh. And with that, I'm going to turn it over to Jessica, and she's going to tell you a little bit about her program.
Thank you, Sabrina. So my name is Jessica Marcum. I'm a community paramedic with the Community Paramedic Program at Umatilla County Fire District Number 1. Next slide. So today we're going to talk a little bit about the program that we've had here, how we got started, give you some stats of our program, talk to you a little bit about what goes into our CP visits here. I'd like to share some success stories about our program, kind of what else we're doing, funding, and just give you a general overview of our program. Next slide, please. So how we got started. We have been mostly on grant funding since the beginning of this. So we started with a grant through I want to say it was through the LCAC, which is the Local County Advisory Committee. I might be getting that wrong. We started with a grant from them that lasted us about 6 to 7 months, I believe. And then we've been going off of grants through the EOCCO, our local CCO here. We started with one full-time paramedic, that's me, and we actually had a part-time position for a little while. That changed because of our funding status, but we had a part-time position as well that helped with our visits. We focused mostly in the beginning of our program to our high utilizers of the ED and our EMS systems. We also focused on our post-discharge patients. So our program is a collaborative program with Good Shepherd Medical Center. That's our local hospital here. And what we did when we first started is we didn't have a very clear direction when we started. So I literally did the most professional thing I could, and I Googled community paramedic programs across Oregon and Washington, and I called them and said, hey, what do you do and how do you do this? And with that, one of our programs we learned quite a bit from was Pioneer Memorial Hospital in Washington, Prosser, Washington. And some of what they did was post-hospital discharge focuses as well as they're part of their hospital system. So we did that. We started out with those. And then as our program went on, we got to actually build a really good relationship with our primary care providers. So we started with that post-hospital, and as I was sending letters, and my partner Galen was sending letters to the primary care saying, hey, this is an update on your patient, they went, well, what else can you do? And that transitioned into more welfare checks from primary care providers. Next slide. So as of September of this year, we've seen over 500 patients. And all of these numbers are estimated based on percentage of patients that come to the ED, come by ambulance, what percentage of patients that get admitted to the hospital as an inpatient due to the amount of ED visits and that sort of thing. So we estimate and avoided over 30 EMS transports. I suspect it's much higher based on some of the other work we'll talk about that we've been doing. 350 avoided ED visits estimated, and an estimated avoided 34 admissions over the last few years of our program. Next slide. So what goes into a CP visit? First, I want to talk a little bit about our program, and we'll talk a little bit about what goes into it and then kind of what we do. So we serve 2 counties. We serve Umatilla County and Morrow County. Combined, that's a little over 5,000 square miles and a population of a little over 88,000 people. So in that, we have a pretty big area, especially for just one community paramedic. So I stay pretty busy most days, but we do have a partnership with our Connections community health workers, and Connections is a program that's funded by the hospital. And they have 5 community health workers and a care transition nurse. So they focus on a lot of the social aspects of things, and I focus on the medical, which is a pretty cool partnership, and I'll talk more about that. But as far as what goes into our visit, we have the typical vital signs, physical exam. We do a lot of education with patients in the home, so disease and diagnosis education, discharge instruction education. We do the same fire and fall risk assessment. So we were donated to, I want to say 50 or 100 smoke alarms and carbon monoxide detectors. So during our visit while we're there, if we see that there's a need for one of those, we can install that during our visit, and it's been pretty successful. We do medication reconciliations. When I last ran the numbers, we had, I want to say like 40%, it was a pretty high number, of our elderly population that were not taking their medications properly. They weren't taking them at all. There's mistakes in their medications. They weren't using pill boxes, those sort of things, a lot of errors with that. We have the ability to do some lab testing. You'll see pictured here is an iStat. Due to FDA changes in their licensure for some of those cartridges, we don't have that available to us right now, but it's been, when we were able to use it, very, very beneficial. We have our X-Series Zoll that you see pictured there as well. So for some of our cardiac patients, congestive heart failure, post-MI, those types of patients, we're able to do 12 leads if patients are symptomatic, and we can send those to their providers. Usually, depending on the location of the patient and the provider, I'm able to print that out as long as everything's stable, go to their doctor, say, here's a copy of their 12 lead. What do you think? If they're having any sort of symptoms, and get some direction from them. We also have a urinalysis machine and an A1C. machine as well. So for some of those patients that may not be more emergent, but have signs of something going on, we can get those test results and send them to their provider. We do have contact with primary care providers. So we've spent a lot of the last 3 years getting relationships with our primary care providers so that they know who we are. If we call them, we're able to get usually to a provider and get some direction with the patient. And then again, probably one of our biggest things is the connections community health worker intervention. So for example, if we have a patient that we go out and see them and go, hey, I think you got something going on. It's not emergent, but we should get it checked out probably within the next couple days. We can call the community health worker to make an appointment for that patient. They can set up transportation for them, and I can provide all the medical information to the primary care provider. And so we have that medical and that social aspect covered in the same thing. Next slide, please. And besides that home visit where we were able to accomplish quite a bit, we do coordination with other services. So you see pictured here, we have a couple of primary care providers. We have our mental health providers, our hospitals, some of our law enforcement agencies. We have, and home health is another one we partner with. We do a full review of their medical records. So for example, say we have a patient who comes in for congestive heart failure. We can sometimes have the ability to, I have a laptop with an air card, so I can take that out with me to a patient's home and go, hey, you're having some chest pain. Let's do a 12 lead. I can compare my 12 lead to what I can see in their medical chart. So that's pretty cool. Determine if there's any differences. And if there are, that's when we make that contact to a primary care provider. Maybe just get sometimes patients, you know, they go home from the hospital or they go home from their doctor's office and you go, okay, well, you know, you got out of the hospital on the 12th and today's the 14th. What did you get diagnosed with? What happened? And they go, oh, I don't know. I had a heart attack. You go, oh, wow, that sounds kind of serious. Let's look at it. And you pull up their chart and they were for something completely different. And you're able to have that, that big patient education moment where you can talk to them about, this is what you were seen for, this is what your discharge instructions say, and here's what we can do going forward to prevent this from happening again. And a lot of that comes back to the education of medications, making sure they have them, they're taking them properly, the home's safe, they understand their medical conditions. And I think a lot of studies have shown that patients learn really well in their home. So when they're getting discharged, you give them tons of information, and the hospital and the nurses and the doctors all do a great job of saying, here's some information for you. Here's everything we want you to know about how to manage your condition. And they get home with a stack of papers, and where do those papers go? Well, they go on a table, in the garbage can, you know, somewhere else, and they don't always learn the best until someone's in their home presenting this information to them. So there's been a huge benefit, at least with our patients, that we've seen of doing that education in the home. And then finally, we do a letter to our primary care providers, and that includes all of our visit info. We started this with, again, modeling Pioneer Memorial Hospital and some of the stuff they do with their community paramedics. And we talked about kind of like our normal SOAP chart of, this is the patient, this is what they said, this is what we found. And we kind of wrapped it up with, this is our recommendation for the patient. So once our providers kind of started getting those, we got the feedback of, well, what does this look like? What does that look like? And so how we write our letters now kind of talks about the general home environment, what type of home they live in. Sometimes it speaks a lot to the situation of the patient. So if they live in a single-story stick-built home, they have family present a lot of the time, they have a lot of medical equipment, they have walker, wheelchair, power chair, that sort of thing, versus they live on the back property in a fifth-wheel trailer, steps are uneven, you know, there's fall hazards. It gives a whole nother picture of what your patient may be dealing with. And if someone orders a walker for them, not knowing they live in this tiny trailer, it might not be the best area for them at that time. And then we can talk about home health and physical rehab and that sort of thing. So we include a little bit about their home environment, what kind of social supports they have. And then we go into kind of like the O portion of our chart, talk a lot about what we saw, any concerns or complaints they have, and then that final one of our recommendations of maybe this patient could benefit from a little bit of this, a little bit of that, and And the providers have been very open to that, luckily. We've been very, very fortunate with that in our area. Next slide. So a few of our success stories, and this is where I get kind of excited about our program because I get to see some of this stuff take effect. So we had one elderly female who we got the 911 call that she refused to take her medications. And, you know, that's kind of not an emergent thing in most scenarios. So we went there and I heard the call because it was the second time within, I want to say, less than 12 hours that we were called to the same address for the same reason. And this is where we've seen a benefit to our ambulance service is I was able to show up and say, this doesn't sound emergent. Let's try these things. And within, I want to say less than 3 minutes, that ambulance was cleared to go into service for another call. Another one was an elderly female who wandered frequently. She would call law enforcement almost daily, at least weekly. Just had some dementia stuff going on and some paranoia. And so we were able to work with law enforcement and figure out how many times she was calling them. And we were eventually able to get her to a facility that could handle some of those things a little bit better. And so we work a lot with our other emergency services for frequent people in the community. A frequent faller with injuries for the patient and his wife. This patient was a very nice guy. He had suffered some medical issues and was having a lot of falls. And so I believe we went on this individual probably over 20 times in a month. And so when I was able to connect with him, figure out what was going on with him, we were able to get some different equipment, got some strips so that he didn't fall, maybe some different socks, worked with a physical therapist. He actually has much less falls, and he ended up being a little bit safer. He was getting injured with those falls. Another patient, again, he called twice in 1 week for a fast heart rate. I responded with the ambulance on the second one, the second call for the week, and was able to find out he had been in the hospital probably a month prior. He still had his discharge instructions. And I was looking over him and went, well, tell me about your medications. Like, this is the heart rhythm that you have, and this is the medication that normally fixes it. Why aren't you taking that? And he said, well, I don't know. My doctor took me off of it. So while I was there, I was able to make a phone call to his doctor, got him an appointment for that afternoon, got him transportation. He got put back on that medication. And to my knowledge, we haven't been back on him since. So there's many success stories, I think, both me and Sabrina and every program that I could talk about. But these are just a few of ours. Next slide, please. So about a year into the program, we started doing some surveys to our primary care providers, some of our EMS providers, and our patient. I wanted to share some of those quotes with you guys today. All right, well, so some of the quotes that we got back from our providers, and I just want to highlight a few things of what they said, is the CPC gives excellent reports summarizing their home environments. They paint a picture of my patient's living conditions that really helps me fully understand my patient. And then they talk about also that we are their eyes and ears in a way that they can't be in reference on getting data of patients. Sometimes the information we're able to give as community paramedics and doing home visits with patients are huge, and it makes quite a difference in how they treat patients sometimes, and knowing what the patient might be capable of and what they won't be. Next slide. So some of our EMS provider quotes, we also surveyed our duty crews to see, what do you think of this? When they first got told we're having a community paramedic, both them and myself went, well, what does that look like? We don't know much about community paramedics. So after about a year of being able to work with some of our providers and responding on our 911 calls as well, and that's kind of the thing that I love, is I've gotten fairly good with addresses, and when I hear one of my patients or maybe a frequent utilizer of our EMS services, I'm sometimes able to respond, a lot of the times able to respond to the scene and see if there's anything that we can mitigate there in the home. So one of our EMS providers, one of our lieutenants, stated that they've been consistently and aggressively pursuing every patient that they refer to us. It's been a big benefit by reducing some of our 911 calls and burden on our duty staff. So, and then one of our firefighters talked about, it puts patient at ease when they're able to confidently say how helpful we are. And that's been a huge benefit to our system to reduce those calls. And also it's a huge compliment to me as that's been, I'm trying to figure out what to say here now. It's been nice to be able to have that relationship with our duty staff and being able to run 911 calls and do a post-hospital visit as well with our providers. Next slide. So other things that we're doing, we participate in the Oregon CP MIH Coalition, like Keshia and Sabrina have talked about. We're trying to expand knowledge of the CPP program. We do some community involvement. We're involved in some school presentations, career days, that sort of thing. Next slide. Our funding's been an issue, just in the fact that we haven't found a sustainable force yet. Of course, we have the funding from the fire department. Good Shepherd Medical Center has been a part of it. Our Umatilla Hospital Board, and of course, our contracts with the EOCCO. Next slide. And that is it for my presentation, and I'll turn it back to you, Rebecca.
Okay, so much, Keshia, Sabrina, and Jessica. And we will now go to the live question and answer session. Okay. Hi, everyone. Just letting the video catch up here. Thank you all for joining us for the session. And I think I see most of our panelists joining in live. We have had some questions come in. I see that Keshia started to answer, but I want to make sure that we put it out there. The first question that we had was from Carrie Galpin, saying the program sound really amazing. Thank you for sharing. I'm curious if patients are identified for referral to MIH. And Keshia, can you amplify your answer for everyone? Maybe doesn't see the Q&A box.
Yeah, can you hear me all right?
Yes.
Okay, great. Yeah, I was just answering in the Q&A section there, but basically I think most commonly they'll get direct referrals from providers or care teams, and then in a more structured way through care coordination or case management teams, either attached to like primary care or to like the CCO or the payer. And then sometimes there's very targeted partnerships when they're building the programs. So the referral pathway is identified as part of that program development.
All right, great. And just as a quick reminder to participants, you can post your questions in the Q&A box for me to read out. And our final other panelists, Jessica and Sabrina, if you're able to unmute or turn video on for folks to see. We did have another question. This is a little bit actually of an aggregate question. On the app, people are really curious who financially supports this program. And I know you answered some of that specific to your programs, but what are, who are the specific funders or resources that you look to when you're thinking about funding for community paramedicine?
So I can take for our program, we are funded through a contract with one of the local CCOs. We partner with Jackson Care Connect down here in Jackson County, and they're the ones we receive the referrals for, and we're able to work with. And then for our community outreach, we just work along those patients. And honestly, we don't necessarily really receive a lot of funding for it. It's just to help the patients out. And so our suggestion is working with your local CCO in your area, which is, for those that don't know, is part of the Oregon Health Plan. And they're really good resources for funding these programs and working with their members and wanting to improve outcomes. And I think Keshia can talk a little bit about that, about the programs up in her area, and maybe a little bit Jessica.
Yeah, Thanks, Sabrina. So I actually work with a CCO, so I'm kind of the partner to Sabrina in a way for funding. But the way we've done it is for programs that we're attached to, we have a contract set up with our transporting agency partner in the region. So we partner with a fire and rescue agency. And so we've just set up a contract where through the contract, we've provided just kind of a lump sum grant. And we're actually in the process of developing more of a value-based payment model to pay for the program from a more sustainable place. There isn't a way to really bill for this work through a fee-for-service mechanism. They do that in other states, but we don't really have that option in Oregon at the time. So, at this time. So I agree with Sabrina. I think like one of the best avenues would be really partnering with your CCO because they are connected or should be connected to kind of the provider network at large within your region. And they'd be a great partner to facilitate conversations and key strategic partnerships and have different options for funding this type of work through, contracts, grants, value-based payment arrangements, and other things like that.
And to answer both questions a little bit of how we get our referrals, I'll just kind of echo what Keshia said is when we first got started, went and talked to our hospitals, our community partners, and said, this is what we are, this is what we do. And they started sending referrals to us with that. And as far as funding, I don't know if anyone's really got this figured out very, very well. We haven't got it written into legislation yet to get paid for in that fee-for-service like Keshia was talking about. So I know as a coalition, we're working on that and trying to model some other states. But for us in Umatilla County, we've worked with our local hospital. We're trying to work with our CCO on getting that contract. And we've also got some in-kind funding from our fire department and also one of our local hospital districts. So the short answer is we're getting a little bit here, a little bit there. And we're just trying to make it work until we can get that legislation passed to get it as a paid for service for everyone across the state.
We have another question that came in from Patsy Dryden to all the panelists. Question is, I work for an AHEC, an Area Health Education Center, and often get questions from community health workers asking where they can get education to meet their annual requirements. Is there somewhere I can refer them?
Well, so this work's community paramedicine work, not necessarily community health worker work. But I do know that there's a list on the traditional health worker website on OHA that you could probably look at for that.
And so for what our team does is we actually are able to go into some of the CHW classes here in Jackson County are offered through Road Community College, and they do it twice a year. And a lot of times they'll just open it up if you want to come in and just sit and watch. And then ORCHWA is also a really good resource. They do a conference once a year. And I believe this year it was pretty reasonable and it was virtual. So, I mean, with the time of virtual everything, it's actually kind of pretty beneficial. But if I find any more, I can feel free to send me an email and I'll send them your way.
Hey, Sabrina, what was that last acronym, ORCHWA, you said?
ORCHWA.
Okay.
The Oregon Community Health Worker Association.
Okay, perfect. And for us, I tried to separate myself a little bit from the community health workers. So they have the social aspect, I do the medical aspect, and we do a little bit of overlapping, but not enough to get training on each other's stuff. So.
Yeah, and that's an important delineation between the community health workers and the community paramedicine programs. But kind of as a bridge to that, we get asked a lot at the Office of Rural Health, and it's in line with that AHEC question. Do you have any thoughts or recommendations about what kind of community paramedicine or mobile integrated health programming that our agencies without paramedic level providers can undertake? Is there any cross-pollination there to be had, any 101 or starting point level for so many of our agencies who don't have a paramedic level provider to dip their toe in the water of community paramedicine or MIH.
So I can speak on that a little bit. It depends on your medical director and the scope of practice. We, on our team, we have an EMT, really 2 EMTs and 3 paramedics, counting myself. We like to keep it multidisciplinary, and we worked with Dr. Swayze and Matt Zavadowski out of Texas, and they are really good resources. They also have EMTs, and last I heard, some CHWs on their team, and they are always willing to share, but they also encourage that if it just depends on what your medical director and the scope and the work that you want to do.
Go ahead, Keshia.
Oh, I don't have anything to add.
Oh, okay.
Go for it, Jess.
Okay, sorry. I think there's an opportunity for sure to have an EMT intermediate or EMT basic to jump in there and do some of this work. I know for us, I don't think, at least for a basic, they wouldn't be able to do 12 leads or lab draws or that sort of thing. So we might miss out on a few of those medical side of services. But as far as the education component, where you're doing the med reconciliations, you're contacting primary cares, and you're getting that sort of information pushed out, I think there's a lot of work that could be done there as well, and it'd be just as beneficial almost.
All right. Well, and that brings us to time. I want to thank everybody for their participation. Our panelists, Keshia, Sabrina, and Jessica, thank you so much. This is really, these are such dynamic programs. I really appreciate having you guys present. Thank you to all of our participants. One final reminder that if you have any additional questions, please submit them to the Office of Rural Health. You can do that via the app or our email, and we'll post the questions and their answers with the recording and the slide decks from the presentation on our website. And with that, thank you so much for helping us close out the Tuesday of our conference. We hope that we will see you guys all tomorrow morning for our first session starting at 9 a.m. We have Integrating Primary Care and Public Health, the Douglas County COVID-19 Response Team. And that's kicking off another great day of rural and frontier specific education and learning. Thank you so much. Again, thank you all of our community paramedics for all that you're doing out there to grow this resource in the state. And we look forward to seeing you all again soon. Thanks so much.